cardiovascular health is all of the risk factors that all of your physicians tell you about, your cardiologists and your primary care doctors that say, you gotta watch your blood pressure, you gotta watch your cholesterol, you gotta watch your sugars if you're diabetic, don't smoke, make sure you exercise. All of those rules apply to me. Because if you don't have control of those things, if your blood pressure is super high, you don't have good control of your cholesterol, your sugars are out of whack, then some of these problems will develop. And if my biggest concern is if you're a smoker. If you smoke, these things get amplified even more. So I always tell my patients, I shake my fist of fury and tell them they're supposed to quit smoking because I'm a doctor and that's what I tell you. But that's the biggest thing for me, right? If you're not smoking, most of these things don't happen, but they still do. So let's talk about aortic aneurysms, or AAA is what you may hear. And I'm not referring to your car insurance or anything like that, but more of the aorta, so the biggest blood vessel in your body. It comes directly off the heart, and this illustration shows once it gets down into your belly. So this is below the arteries that go to the kidneys. The normal one is on the left, the diseased one is on the right. So in essence, it makes a bubble in the artery. The thing that's concerning about this is that a bubble can always pop, and we want to make sure that that bubble doesn't pop. So in order to fix it, we do various things. So to give you kind of a history of AAAs, one of the origins of fixing these was on that guy. You guys should know who that is, right? Albert Einstein. So Albert Einstein actually went to Jewish hospital in 1948, and he was having surgery with a different surgeon. He was a general surgeon, but was inventing a new procedure. It was Dr. Rudolf Nissen. He does what's called a fundoplication for hiatal hernias and things like that. So Einstein went in for cysts on his intestines. He was having surgery, and Dr. Nissen said, wait a minute, there's something there that's not supposed to be there. There's this big pulsating balloon in your belly. So he went to fix it. And the way he fixed it, he actually took cellophane and wrapped the aorta in saran wrap, which was like revolutionary at the time. And most people who have this disease process didn't survive it. Einstein lived for 5 years afterwards. And ultimately, his aneurysm did rupture, and he showed back up at the hospital 5 years later, and they said, well, we can go back and operate. And he said, no, thank you. I'd rather die. Oh. And so that's because then we didn't have any of the techniques we have now. This is Michael DeBakey, which you may have heard that name before, well-renowned surgeon. He's actually hand sewing the material that we use still today called Dacron for bypasses. So the picture on the right is actually what Dacron looks like when we use it in the body. He literally had a sewing machine and hand sewed the devices himself, and he implanted the first one in 1954. So now we're 70 years later, still using the same thing because he was that brilliant of a physician at that time. So when we talk about this aorta that we're repairing, if we use that Dacron, this is more the old school way we fix this. Have to make a big incision, and we put this Dacron tube, which is the picture on the right, we actually sew a new pipe. We take the old pipe, in essence, out of you, put a new pipe inside of you to get blood flow going down to your legs and to your pelvis. But again, I said that's the old school version. We still do this, but relatively rarely. Now we do things, because again, cardiovascular and the cardio part of this and the vascular part, we do stents. So we can actually fix this by way of putting in stents. We can go in non-invasively through the groins into the arteries and deploy these stents to actually isolate this aneurysm. So in essence, the way to think about this is, if you've ever seen an old garden hose, when it starts to break and split and it bubbles out, that's the aneurysm. When I go in and put a stent in essence what I'm doing is I'm relining it to make it a new, shiny, brand new garden hose. Because the biggest risk with this is rupture. We don't want that to rupture. And even if it does, we can fix it in an urgent/emergent way, but we'd rather not get there. So when we know that these things start getting bigger, we go to fix them. And then we can get even more complicated. These aneurysms can be higher up in the aorta, they can run lower down. We can put all kinds of stents to make sure blood's going where it needs to go and still make sure that that garden hose doesn't rupture, right? So this is, again, part of that whole plumber thing. I'm giving you new pipes so that we don't have any risks of bad things to happen. The one everybody always talks about, carotid artery disease. The biggest concern with this is having a stroke. right? And part of what I do is to help prevent the stroke. So if you've had one, if you've had a stroke, the workup that's included is to find out how diseased the arteries are. Was the carotid artery the reason you had the stroke? Or is it because your blood pressure was too high for a moment? Did you go into atrial fibrillation or AFib and a clot went up there? If we eliminate all of those things and we realize that it's the carotid, then we go and we fix the carotid. So this graph is just showing the prevalence of strokes by population and by gender. So it's pretty equal, male to female. Once you get over 80, the number's pretty high. So 14% of people in the normal population run the risk of having a stroke. So my job is not to fix your brain after the stroke, but to keep you from ever having it. And all of you seem really nice, and I like all of you. I would like for that to not happen. So if you see me, part of our workup is to figure out whether or not you need me to do anything, or do we just watch this? And by doing something, this is what we're talking about. So that's the carotid artery in the neck. It lives right in here. And there's two versions. There's one that goes to the brain and one that feeds your face and scalp. The face and scalp part, I'm not worried about. It's the one that feeds your brain. So on the picture on the right, there's that plaque that's in the artery, so it's blocking blood flow. What our concern is, does that blockage, does it shut all the way down, or does it make clots, and those clots shoot up to your brain? So you may have heard like mini stroke, like that term gets floated around a lot. A mini stroke would be you and I are sitting down for breakfast and you go to reach for a cup of coffee and your hand doesn't work. And then sometime in the next 20 minutes, hour, maybe a couple of hours, it all comes back. So that's a mini stroke or a TIA. A real stroke is that happens, but it lasts longer than 24 hours. So either way, both of them are bad, and both of them we can prevent by cleaning this out. So now, the plumber analogy comes back again. We roto-rooter this. So the picture here showing is I go in, we make an incision, we find the artery, we get it all controlled, and then I roto-rooter out this plaque. I get all of it out, make it a nice, clean, fresh artery, and put a patch on it. So before you had this little bit of flow that was going through your artery, now you have this huge pipe. So jokingly, I'll tell patients, if you couldn't play the piano before, maybe you can now, or the guitar, or maybe you can sing. Not really. But that's the idea. Roto-rooter this plaque out to eliminate this risk. If we can get rid of this risk, then it's just a medication issue, right? Then we can make sure your medications are good. We look at ultrasounds, try to fix this thing. And then still going through newer techniques that we can do, we can actually stent this instead of having to do the full roto-rooter. And what this picture is showing is that the picture on the left is just a newfangled way that we do this, where we can almost eliminate the risk of having a stroke with surgery. We do this fancy thing called flow reversal. And not to go into any detail, but in essence, we make sure that we protect your brain, and then we can go in and put a stent. And then that's what this looks like when we're done. There's the plaque, we go in, we put a balloon with a stent attached to it, balloon it in place, problem solved, right? Then it's, again, medication issue. So moving down the body now, we're talking about peripheral artery disease. So now the legs. So again, same type of problem, same type of blockages, but now we're talking about with the legs. And what I see with patients who come in with this, they sort of walk in and they say, oh, I didn't turn it up. Did I turn it up? Sorry. What they'll say is, I can walk maybe a block and a half, and I get a Charlie horse in my calf. And I have to sit down for a few minutes, I massage the calf, the Charlie horse lets up, I can go back to walking again. So it's life limiting. The thing that's more concerning that this picture shows is that if that blockage is severe, there's numerous blockages, then you start getting bad things like pain when you're trying to sleep. Your foot feels like it's on fire, you have to get up, you may go to the bathroom numerous times because that pain is waking you up and you're walking around to get rid of it. Or, God forbid, you get an ulcer or a little wound on the tip of your toe that doesn't go away. That's when you come to see me. So the initial way that we try to treat these types of things, again, with stents. So we go through, the picture's a little blurry, I'm sorry, but we can either just balloon it, we can use balloons that have medication to try to keep the blockages from coming back. We can put in stents. The middle picture on the right shows that roto-rooter type thing again. We go through and just chew up the calcium and try to get it out of you. And we can leave stents that have medication to try to prevent this from coming back, or at least give you a longer period of time. This is kind of our first line attack to get rid of some of this disease. But then again, I'm a surgeon, so I like to cut things. And I tell people, I'm a hammer and everybody's a nail. So I have one job, is to try to operate on everybody. That's not really true. But if this type of thing doesn't work, we have open surgeries that we can do. So we can do bypasses. So sort of like when you talk about like a cabbage or a heart bypass, they take the vein out of your leg. We use that same vein. We'll take the vein out and we'll use it to bypass from where the artery is good, cross all those blockages, and plug that vein in where the artery is good again, so that we eliminate those symptoms, get rid of the Charlie horses, try to get those wounds to heal, things like that. If we can't use your vein, we also have some of those bypass grafts like we talked about. Dr. DeBakey made those Dacron grafts. We use those. We have what's called PTFE, or basically plastic that's waterproof. We can use those as well. So the way that I like to describe it is, in essence, you have a bridge that's broken, and I'm making you a new bridge. Okay? So I want to get all these cars around that blockage and get it over the river. So that's what my job does, right? So that treats all of the artery side of things. The one vein thing that we'll talk about today is DVT. I'm sure you guys have all seen the commercials about DVTs or PEs, pulmonary embolism. We treat those as well. So when you have veins that are healthy and blood can flow through, you don't really have problems. It's when the blood stops moving. So blood moving, good. Blood not moving, real bad. When it's not moving, it likes to clot. So if you have those varicose veins, that tells me that your veins aren't really working the way they're supposed to, and I want to make sure the deep veins are healthy, that they're not making clots. And if they do make clots, then you get on these blood thinners. Same blood thinners as for atrial fibrillation, but different doses because we're treating this clot. God forbid this clot takes off and goes to your heart and lungs and you get the PE. It just so happens that we also treat that. This is an actual picture of a case that I did. My wife was like, oh, you should show that to them. And I don't want to make anybody squeamish with lunch, but the pictures in the middle actually show when I took an x-ray with contrast. I used the dye like for cardiac caths, and you can see, I'm going to sneak up here, there's all this stuff in here that's not supposed to be there. It should just be plain black. And what we ended up doing is that big tube that looks like it's pointing at that big white spot, I sucked all that clot out. So this patient came in, low blood pressure, high heart rate, not feeling well, needing fluids to get their blood pressure up, not able to get oxygen to their extremities. We sucked all this clot out, and you can see the pictures of the lungs where it's nice, you can actually see the lung, and immediately the patient got better. So they were awake while we did this. And their heart rate comes right down, blood pressure goes back to normal, and then as we get all the sedation, they had some sedation. When the sedation starts to wear off, they're like, I feel amazing. I feel so much better. And then they stay in the hospital a couple days, we get them home, they go back to normal life. That's our goal. I also tell people, aside from being a plumber, I'm also a janitor. I try to fix all the problems that are out there. So if there's a problem that somebody else can't do, they call me. And then I try to figure it out. Lastly, that I'll talk about today is dialysis access. It's one other thing that we do. So if you or anybody you know that's on dialysis, we create that access. So we connect the artery and the vein together so that if you go to a dialysis center, they can actually take your blood, clean it, and give it back to you. And we do that with either sewing the artery and vein together themselves, or again, using that plastic vein that we talked about, that plastic tubing, and creating a vein so that the blood can flow through, the dialysis center can figure out what they're doing, stick it, clean your blood, and then get you home, all right? So with all that being said, again, I am that plumber, but I like to think I'm more like this guy, the video game, or Super Mario, and then I can do some work like that with him. Does anybody have any questions? Yes, ma'am.
I have neuropathy, okay? And unfortunately, when I have a glass of red wine, I get cramps in my feet.
Okay.
What is causing that?
That's a good question.
Wine, I know.
Well, it probably has to do with the wine. I would venture to say that the alcohol is dehydrating you, and that's why you're getting the cramps. Because one of the biggest misconceptions that people ask me constantly, like somebody will come in for, say, a DVT, and I put them on the blood thinner, and then I'll see them a month later and check to make sure the DVTs are gone. And they ask me, well, can I drink with this? And I tell them, of course. I mean, I'm not telling the 65 million Americans that are on some type of blood thinner they can't have a drink. But you have to be careful. The reason they don't want you to drink is if you drink and fall down because you drank too much, then you have a bleeding problem. We don't want the bleeding problem. But typically speaking, with wine, because alcohol in general, it throws everything off with your fluid balance. So I would venture to say if you have neuropathy already, that the nerves are just firing out of control, and then being dehydrated is making that a bigger problem. Now, that's without me feeling on your feet to make sure you have pulses. Oh, even better. Yes, sir.
I've heard a lot of talk lately about stents, the pros and cons of stents. Is there any reason why there should be a con for stents? I mean, aren't they very helpful?
They are very helpful, and that's a good question. So the way that I trained as a vascular surgeon was I don't want to leave something behind, right? The only thing that I would like to leave behind is the medication to try to help keep this disease process from going back. The problem is that a lot of times the disease process is too good. It's too strong, and I can't really get rid of it with just a balloon or just the medication. So the stent works as a scaffolding. It works as trying to rebuild the wall of that vessel to keep all that disease out of it and give you a nice open pipe so that blood can flow. So the pros are that it gives you that stability in the vessel, it gives you strength, it keeps the vein or the artery open, but you have a foreign body in you. And it's incredibly rare, but you can react to it. I think I've had one patient in 15 years who actually had an allergic reaction to a stent. And that's thousands and thousands, even with my colleagues. Nobody sees that. But the one thing that we do see is that once you put a stent in, you are more prone to having that disease come back because your body says, there's something wrong with that artery, there's an injury and I need to fix it. And in the process of fixing it, it's actually making it worse. So the medication I put you on tries to stop that process, but I can only do so much. And the medicines can only do so much.
Question here. Is there any, right here, is there any kind of pre-testing you should do before anything starts happening?
That is a wonderful question, and I'm glad you said that because you reminded me to say so. So there is. So if you have risk factors, if you have high blood pressure, you have diabetes, you have high cholesterol, you're a smoker, and especially if you're a man, then one of the Welcome to Medicare packages that you get is that you can get a carotid artery ultrasound and an ultrasound of your aorta. The leg portion, usually, if you have those symptoms, that's when it would show up. You would tell your primary care or something like that, then they would refer you to me. If you had the cramping or the wounds that weren't healing very well or something like that. But most of those ultrasounds are part of the Welcome to Medicare packet. And as long as you meet that criteria, if you've never smoked and you're completely healthy and you try to get them, then Medicare is going to be mad at you for trying to scam them. But that's the idea. And one of the things with AAA is if anybody in your family has ever had one, if your mother, father, your brothers or sisters, if anybody's had one that you know of, there is a family history of that. So you potentially could inherit a somewhat, we'll call it a weaker aorta, that would make you more disposed to having an aneurysm. So that would be another reason to get those ultrasounds taken care of. And once we see something that looks like there's a disease that we need to treat, then we could do more things. So we start with the easy stuff, the non-invasive stuff, ultrasounds. If we need to get CAT scans, we get CAT scans. Then we start talking about if it's something that needs to be treated, how to treat it. And 99.9% of the time, let's say with the aneurysm, we treat it with the stent. It's not very common to do the open surgery anymore. More and more patients are now getting the carotid stent because they just changed the indications for that. So now if you meet the anatomic requirements that I need, I can put that stent in you. And that's a much easier surgery to recover from than the other. Yes?
A friend of mine had a stroke and then he gave up smoking, but now he's vaping. Is he much better off? Is he a little better off? Is it better than not if you go back to smoking?
Smoking is bad. The only thing that vaping is good for is if it's purely without nicotine. So if you're only doing the actual water vapor, I would tell you, like my party line as a vascular surgeon, don't do anything. Don't inhale anything except for some of the wacky tobacco. That's okay. No, I'm only teasing. But anything with nicotine, anything like that is going to cause this situation. You're going to have problems with your vasculature if you're smoking. So even vaping, you still run that risk. It is, we'll say, better, but it's really not that much better.
I have 2 questions. Regarding an Abbott Merlin battery loop, what's the lifetime of that particular battery? Okay, question from the audience. Okay.
I don't know.
Okay.
Sorry.
Okay. And the other one is 4 stents in the heart. Do they need to be replaced at any point in time?
No, so whenever, heart-wise or in the periphery, when you put in a stent, that stent stays with you forever. You own that stent, it stays with you. The only reason we would ever take a stent out is if it gets infected. And if it gets infected, to take it out is somewhat expensive. So we typically don't get to that point. It's again, very rare that stents get to the point we take them out. So if you have stents in your heart, when you see your cardiologist, they're doing echoes and they're checking everything to make sure things are good. If you start, let's say you have a stress test and it's abnormal and they need to do another cardiac cath, they may put a new stent inside of the stent to try to open that disease back up and get blood flow going again. But it's not a situation where they go in, take one out and put a new one. The new one does its job inside of the old one. Yes, ma'am.
Is it the same as well with a bypass surgery? Is that good forever, or does that need to be looked at after X amount of years?
Sure. So I tell all of my patients, especially any patient that I've done any procedure on, you and I are friends forever. We are friends for life. If you've had a bypass, I will follow that bypass. Even if it's every year to make sure it's okay, I will follow the bypass. If you have stents, I check those. You do open surgery, I check that as well. The bypass, so the bypass itself is more, we'll call it morbid, if you will, because you're having to have actual surgery, right? We have to open up everything, make incisions. You get swollen, you may have difficulty walking for a little while, like rehab type things. But we tell people that a bypass is going to give you the best long-term success. It's going to do the best overall. But if I can achieve a similar goal with doing a stent, right, I can open up blood flow, and let's say you may have to have that procedure again in the future, like 2 years or 3 years later. That's still better than having the open surgery for some. But either way, they both have to be looked at. Some patients get a stent, they change their lifestyle, they do really, really well, never have a problem. We just monitor it to make sure. Bypass is still, in my mind, a bypass is still the gold standard. It's still the best thing I can offer you, but it's not necessarily the right thing to offer you. So I'm not going to tell you if you come in and you're having trouble walking, you have a very, very, very small blockage, I'm not going to tell you you need a bypass. Because that, again, I'm a hammer and you're a nail, I should operate on you, but it's not the right thing for you. So it's case by case, person by person, what's the best thing to give you the best success. I hope that answers your question. Yes?
I'm an alcoholic, and I quit in 1979. And I quit cigarettes in 82. And about 15 years ago, I woke up and I couldn't believe it. I was blind. I said, what the hell is this? And then it was all dark, and I didn't understand what was going on. And then in about 2 or 3 minutes, all these huge colors started going up and down, and purples and deep blues. It was gorgeous. Sure. And I'm going, I saw the cardiologist for ischemic, they tested, but it never happened. I mean, nothing came of it.
Sure.
But I had a big argument with a nurse, and she said, Al, that's impossible. That could not happen. I said it happened to me, you know? But, that was, I still don't understand why that happened, but it did. But now I have after effects in the last year or two.
Okay.
My right eye blurs. It's like shattered glass.
Okay.
It comes and it goes. And I wanted to get some back surgery, but I can't because I have a cap in my heart
Okay.
left over, and they said you gotta go to Philadelphia and get the cap removed, and you could die of bleeding. And right now, I'm up in the air about that. But I want to know, how dangerous is this glassy thing that comes and goes? Or have you ever heard of that?
So all of those symptoms, like these TIAs or the mini strokes, they all can present differently. They're different for every individual. So from my standpoint, like if you came to see me in the office, I would make sure that there wasn't a vascular reason that that was going on, right? To make sure that it's not this artery that's causing those problems. But so what I unfortunately have to tell people is I can at least tell you it's not me that can fix it, but I can't give you the right answer. I can't tell you why you're having those problems. That happens, unfortunately, more often than I'd like to admit to. So at least I can figure out, is it something dangerous from my standpoint that we would need to fix to eliminate that? But the problem with strokes in general, or mini strokes, is there's a number of reasons why you can have them. And one of the easiest, simplest ones is your blood pressure is through the roof. Like if you get really stressed out and you're doing something you're not supposed to be and your blood pressure is 240 over 120, you can have a stroke, right? And you can have those, I'm not saying it's you, I'm just saying that's a situation. So that's one of many reasons to have mini strokes or full-blown strokes. So me as a specialist, if you will, my job is to figure out can I fix what's going on? Can I fix or help you in those symptoms? But at least for everything else, if you're going to see a back surgeon or anybody else, I can at least clear you from my standpoint to say, it's not a vascular problem, that's not going to be an issue, and whatever you need to do, you can do. So,
I do have a follow-up on that. I take a lot of medication.
sure.
And I'm thirsty and dry all the time. And I drink tremendous amounts of Perrier. That's the only cold. And that seems, is drinking all that Perrier harming me?
Well, I would tell you just drink water, and not the carbonated water.
Okay.
But that would be my first thing. But because there's another speaker, I don't want to occupy all of his time, and I apologize for that. But I'm going to be around. I'm not going anywhere. If you have questions after the lectures are done, while you're eating lunch, or if you're here and you want to ask me other things, I'm around. I'll be around. I have cards and things over here in case you want to reach out to me afterwards, in the next couple of weeks. But I don't want to steal any more time. So.